Thank you for allowing me to speak to you today. Good morning. I'm a newbie to the SMA conference, so thank you for welcoming me and allowing me to participate today. What I wanted to do was try to give you a general perspective on disaster medicine and insert some pediatric pearls, perhaps, along the way. I've also asked the SMA staff to put on the website an after-action report that we wrote after the tornado outbreak of 2011. And I think that gets into more of the nitty-gritty of pediatric issues and whatever. So for those folks that are interested, that document should be on the website as well. It may help you drill down into some of the things that, because of time, we're not going to be able to get into great detail. I'll also be glad to make myself available for the rest of the day and evening, and certainly people are welcome to contact me by email, and I'll be glad to try and help you as well. I don't have any disclosures to pass along. The opinions and experiences that I relate are basically my own, so take that for what it is. I think before we get started, we need to acknowledge that the field is not one that's conducive to evidence-based research, because you cannot do these kind of studies in this kind of environment to any great degree. So there's no randomized controlled trials for most of what's out there. But I think you can extrapolate from experience and routine care operations. And I think one of the points I'm going to make is if you can execute your routine operations well, you'll do well in most disaster situations, because that's the basic skill that you need to be able to do. I've got some military experiences, and the military does a good job of passing on their experiences as well. And there's quite a few case and event reports out there as well. I think the real truism is that critically important clinical interventions, that time is critical, but a lot of disaster issues do not involve highly time-critical interventions, so flu epidemics might be an example of that. So what I'd like to do is to try to go through things in general, and hopefully you can sit back and listen, and hopefully this will catalyze you to re-examine where your context lies and realize that it's important to periodically go through these issues so that you can maintain a satisfactory state of readiness and responsivity. I'm going to try to organize things into three broad categories, which I think will help you think through things. One is epidemiology, one is planning, and one is the actual response operations. And at the end, we'll talk a little bit about some of the lessons learned from Katrina, which I think was a very big learning curve experience for our country and many of us. So let me begin with some epidemiology issues. And there's a fair amount of myths out there as far as what the epidemiology is, so I think it's important to have a little bit of an understanding of this so that you don't end up spending your energy on things that are extraordinarily unlikely to happen or be pertinent, and don't overlook some other things that may be more important than you think. Most major disasters in this country are due to accidents or natural events. Unfortunately, we do have some intentional acts out there, and occasionally we run into resource shortfalls for other reasons. Most disaster events that we encounter in healthcare are relatively small scale. So 10, 20 victims is a typical moderate disaster that we're likely to encounter. The major disasters are very rare. There's probably 10 to 20 events a year in this country that involve more than 50 victims. So you can see that over the course of a few years, the South will experience maybe one or two of these. So, the floods in Colombia and maybe the floods in Texas recently would be, our quota for this year, perhaps. This doesn't include the flu epidemic and some other infectious disease and other surges that typically happen on a expected basis in this country. Most events are hyperacute or acute. You get a mass casualty surge for 12 or 24 hours and that's it. But some are long-term, and flu epidemics is probably a good example of this. Drug shortages are a growing example of this as well. Have a longer, more chronic course. So for hyperacute and acute episodes, typically you need to sprint for a short period of time, so you can throw a lot of resources at it for a short period of time. The longer term ones, you have to sustain yourself for a long period of time, so you can't throw all your resources at it on the first day and expect that people aren't going to be exhausted and be able to keep that pace for the time that it really requires. We do occasionally have episodes that do have a prodrome or a predictable, so hurricanes are probably a good example of this. And you can do some things during that prodrome when you know it's coming to get things prevented or better mitigated. This is a pretty important slide here. We know from experience that the same issues seem to happen over and over again in disasters. As with any organizational issue, leadership and teamwork are always issues. One issue that commonly comes up is very large numbers of people show up and want to help. They're well-intentioned, but they actually end up getting in the way of effective responses. There's also a lot of people that want to watch, and so that needs to be managed. Communication and coordination tend to go pretty well as long as communications are preserved, but when the communication infrastructure goes away, then this becomes very, very difficult. Fortunately, in this country, over the last 10 years or so, communications have gotten pretty well hardened, so odds are pretty good that you're going to be able to communicate to some degree, but you still need to be prepared for that. I think one of the things that's fairly commonly underappreciated is situational awareness. People need to understand what the situation is so that they don't end up stepping in harm's way. So, for example, if you are unaware of the true infectious risk and you infect a bunch of your colleagues as a result, so maybe the anecdotal case of the people in Texas that were exposed to Ebola and didn't really quite understand the risk of that. EMS and first responders out in the field, this is even more important issue. So, for example, going down into a manhole is a very dangerous thing because it's an oxygen-depleted environment because of all the rotting material in there. There's no oxygen, so it's not unheard of people dying because they don't understand that. So those are examples of what you need to be aware of, and that needs to be communicated across all the people so that they're aware of it. We occasionally have problems where people don't quite correctly understand the issues, and that ends up having people go off on tangents that aren't quite as productive as we would desire. Financial repercussions are important. I'm not going to spend a lot of time on this, but it's got some serious financial risk, and in particular in pediatrics where things are based on Medicaid, you can have some pretty serious problems getting reimbursed for the costs of a disaster response. And I will debunk the myth that a disaster causes widespread infectious disease outbreaks. That is almost unheard of. So we keep hearing that over and over again, but that generally does not happen. One of the things that's important to understand in this is what I would term resiliency. And resiliency is the ability to return to a functional state after a stress. And this is a common thing that we deal with on a day-to-day basis in our healthcare system. For example, from the ED perspective, we always have overcrowding and boarding problems. There are shortages of ICU beds or specialists. there's financial and social issues that get into all this as well. So, for example, we migrated to a new electronic health record application about a year ago, and this brought us to our knees for weeks. We had, prior to this, a productivity rate of about 2 to 2.5 patients per hour per physician, and we went down to about 1 because of the complexities and rough edges of the new electronic health record. And we also had kind of a perfect storm when this happened, that we were in the middle of a flu epidemic and seeing record numbers of patients. And we could not overcome this with brute force. We couldn't throw enough people at it to overcome it fully. And so that's just an example of why resiliency ends up being important. So whether that was an atypical disaster or a resiliency problem, we can split hairs a little bit, but be aware of those kind of issues. So how does this apply to pediatrics? Well, if you have a disaster event that affects the general population as a whole, 25% of that population is going to be children. So you're going to see some pediatric victims of that kind of event. It's possible that you could have a context where it selectively chooses to affect pediatric patients. So something that happens at a school or a daycare is going to approach 100% pediatric patients. Adolescents tend to be on the cusp of pediatrics and adult medicine, so those people may be able to migrate one way or the other, but very young children still constitute almost 10% of the population, so those children are not going to be so easily absorbed by the adult side, for example. So you're likely to see some children if it happens. Let's talk about the pediatric resources that are out there. I think this is kind of telling as well, because we don't have the surge capacity for some things related to pediatrics in this country that we might think we do. In general, ED visits, 20% of them are for pediatric patients, so that ends up being about 30 million ED visits a year. Obviously, a lot more end up seeing their primary care sources of care, but this just gives you a vignette of what's involved. About 80% of pediatric ED visits happen at general community hospitals. They don't happen at children's hospitals or other major pediatric facilities. And about 70% of these facilities only see a few pediatric patients a day. So it's likely that it's going to involve community hospitals to a more significant degree than it is children's hospitals or major pediatric facilities. There's about 5,000 hospitals in the United States, but less than 10% of them provide moderate to high-level care for children. So you can see there's not the capacity for mutual support or sharing the problem that there is from the adult side of things. There is some capacity, though, for the adolescents and older children to be absorbed by some of these adult facilities. So instead of making the cutoff at 15 or 16 years, we can make it 20 or 21 or whatever, and probably not have any real significant impact on the facility's ability to take care of things. The big issue happens in the high-end specialty care side. There's only about 200 hospitals in this country that deal with those kind of patients. And most of these hospitals operate near capacity on a day-to-day basis. So if we ended up having a disaster, 15 to 50 patients would probably overwhelm most of these facilities. So there's not a whole lot of surge capacity out there. So an example would be somebody that needs pediatric dialysis. That is going to end up being handled by a high-end pediatric facility. The other problem with these facilities is in most parts of the country, there's one instance in a major city, and then it's a few hundred miles to the next one. Whereas in New York and the West Coast, in the megalopolis areas, there are multiple instances. So in those situations, they can provide some pediatric mutual support. But the rest of the country, you're going to need transportation to move a seriously ill patient a couple hundred miles to the next instance that it's available. So this is a real problem that I'm not sure our country has quite gotten its arms around yet. So here's a map of the south central U.S., and you can see that a couple of the big cities in Florida have several instances nearby, and they can share the problem. But places like Mississippi and Alabama, you're going to have to transport somebody 100 miles or more to get to the next instance if you exhaust your resources. There's been some effort in the last decade to try to assess the pediatric readiness of emergency departments. And this has revealed that we're not there yet. We've got some room for improvement. Over the last several years, people have improved, but we still got a ways to go. And the big issues are generally equipment and supplies. And the problem with pediatrics is you need the spectrum from a newborn baby to an overweight teenager, and that equipment and supply inventory is costly and hard to maintain. Another pediatric pressure point is family reunification. What we've seen in previous disasters is that children and parents tend to get separated, and it's very hard to get them reunited. And we'll get into that a little bit more when we talk about Katrina. Not very many places spend time training or drilling with respect to pediatric issues. And as we talked before, it's likely you're going to get a few of them. So it would probably be helpful for many organizations to look at that and see if they can throw a pediatric patient or two into their drill routines. Special needs children are growing at a steady rate. These are children that require a pediatric specialist to help them thrive, or require devices that to help them thrive. And so the number is getting pretty large, and it's very hard to support them outside of high-end pediatric facilities. So this is some data from the Readiness Assessment Group, and it's from 2013. And basically, a perfect score is 100, so you can see that we've got some room to improve. And this score is comprised across 10 different dimensions, including training and equipment and staffing and other things. And you'll also notice that facilities that see a high volume of patients tend to do better, and as would be expected, those that encounter it less have a lower score. And here's a little drill down that talks about pediatrics and disaster plans, and you can see that about half have addressed the issue and a half haven't. And I've included in the slides a couple references for those who are interested in drilling down into that issue a little bit more. There's some checklists and other criteria that might help you. I want to talk a little bit about the financial issues one more time, and then I'll focus on other things. Most pediatric patients are insured, and most of them have Medicaid or S-CHIP. The problem with Medicaid is that it doesn't pay real well, and a lot of providers don't accept it. And we found over the years with other disasters, including Katrina and others, that it doesn't cross state lines very well. So one of the problems with this is being able to get reimbursed for what you do during a disaster can be a real problem, and that seems to be a continuing barrier, unfortunately. I want to talk a little bit about planning issues here and help you focus in this regard. So the government defines a disaster as a state when there is a declaration of disaster by an appropriate authority. That doesn't really address the problem as we need to address it. You can have a disaster that affects your institution, your practice, but doesn't warrant a government declaration. So I think probably a more meaningful definition for all of us is a state where medical resources are unable to meet the needs for medical care. So this is very analogous to shock. If you remember, shock is a state where the delivery of oxygen is unsatisfactory to meet the demands for oxygen. You can see the parallelism, and I think if you have experience with shock, you'll find that there's a lot of other parallels as well. So this definition basically tells you all you need to know to be able to respond to these things. You can either increase or redistribute the delivery of resources, or you can decrease or redistribute the demand for resources, or you can do both. So that's the bottom line in all this. Now let's talk a little bit about how we can go about some of this planning. I think my own experience is that it's best to do what you do normally and be able to do it well under a stressful situation, rather than trying to go off into some unfamiliar territory that you don't typically do. There are situations where there's going to be skills that, or processes that you have to dust off because you normally don't use them except for disaster situations. So for example, high-end personal protective equipment, you don't do that except when a disaster rolls around. So that one you're going to have to do some quick update on and be able to do that. But the processes that you normally use to take care of patients, you should stick with those and not try to change that into something that's foreign and unfamiliar. You're going to be a lot less effective and a lot less efficient in general. The risk of events is important to understand as well. Risk is the product of the probability of a triggering event happening and the probability of an impact resulting from that. So for example, if the risk of an airplane crash is 1 in a million, and the risk of a child being on board that plane when it crashes surviving is 1 in 100, the risk of that causing a child to show up in your ER in a disaster event is 1 in 100 million. So that is a risk that's far beyond buying a lottery ticket with the hope of winning the jackpot. On the other hand, if you look at flu, for example, where it's 100% chance that there's going to be a flu virus going around this fall, and about 30% of kids are going to catch that virus, and they're going to show up in their doctor's office or the ER for evaluation, then you know that that's going to be a big deal. And that's something that you should focus on. Resource delivery is important as well, and we'll talk about that in just a minute, but you need to think about ways that you're going to deliver resources to resupply yourself apart from your usual inventory channels in these situations. It's really important to make your processes scalable. And again, you don't want to go off on a tangent and do something different. You want to just do more of what you normally do if at all possible. There's been concern about just-in-time inventory issues. It's a risk, but people haven't really seen a big issue with it so far. So that one, I think, is more theoretical at this point in time. Regulatory issues end up being a concern as well, and what tends to happen is we overinterpret the regulations. So for example, we get concerned that we can't talk about things because of HIPAA. Well, actually you can. Taking care of patients is allowed under HIPAA, and you're allowed to share information with other doctors or other people with a need to know under HIPAA. So there isn't a prohibition on not sharing information, and that can be done over the telephone or whatever. So let's talk about, I'm sorry, I'm going backwards here. So let's talk about our mission in all this. Again, our mission is to do what we normally do. Our mission shouldn't be to do something that we don't normally do unless we have to do that. And we want to try to do the right things. So when we plan, the box in the green color is the one that you really want to plan for. And these are things that are likely to happen and likely to have a big impact. So flu epidemics would be a given for most everybody. The yellow ones you need to think about a little bit, but they're probably not going to require a lot of effort in most cases. So the mass casualty event would be an example of one of those. Things in the red zone where they're not going to happen, or if they happen, they have such a low impact that they're trivial, you don't want to spend time on. One of the problems with this is that common risks we get desensitized to. So the risk of getting in an automobile accident we don't think about, but the risk of getting struck by lightning after somebody else gets struck the previous day ends up being on our radar. And we get hypersensitized to these tragic but unusual events. And one of the problems in disasters is they end up creating this worried well population. And you get overwhelmed with people that are worried about the issue, and they don't really have the issue in play. So you need to be prepared to deal with that. Resource issues, again, the main issue is having the spectrum of supplies and equipment that will get the job done. Ironically, this has been an ongoing problem over the years. So, for example, 10 or 15 years ago, the government developed these caches of drugs for emergency supplies. Well, they only bought pills, and so there was no way to cover the pediatric population that can't swallow pills. And then they ended up getting some pediatric form factors, but they didn't plan that the pharmacists would have to unbundle them and measure them out and whatever, so that ended up being a problem. So you can see these things just keep coming up, and it ends up being that I think pediatrics is a special use case that we probably ought to deal with more specifically rather than trying to anecdotally discover these things and fix them. Family and caregiver issues are another big issue in pediatrics. Most children require a caregiver to help them with their activities of daily living, and if they have medical needs, to help them with those as well. So that ends up being a big issue. If you use your staff to perform those services, then there's not going to be any staff to take care of the medical issues. So you need to plan a way to try to encourage other caregivers besides your staff to be able to meet these needs. And you're going to have to support those caregivers with food and bedding and whatever else it is so that they can continue to be at the bedside or with the patient. The other problem is families get separated, and the mother's in another hospital because she's sick and the child's in your hospital because they're sick, and trying to keep them coordinated is a big issue, and so you'll end up needing a bunch of support staff to be able to keep that going. Mental health issues are another really big issue. Children don't do well when they're stressed in a disaster event, and as a result, it's really important to get them back to being a child as quickly as you can. So getting them back to school or some other normal child activities to take them away from the ongoing stress is important. There's a very high probability of post-traumatic stress disorders and other mental health issues and situations where that doesn't happen. Disaster plans are useful, but they're not useful if you create a very rigorous, detailed plan. Your disaster plan is going to last about 5 or 10 minutes, and then you're going to have to start adapting it. And so it's really important that you don't spend a lot of time building a disaster plan that, 8:05 we're going to brush our teeth and, 8:07 we're going to wash our face. That will not work. It's more important to have the goals or objectives and work from there than to have a rigid plan. And it's really important to have the reference information so that when the issue comes up, you know who to contact or you can reach that. You're not going to remember it in the heat of the moment. And this is something you do every day. So again, we're back to doing what you do well. Let's talk about how to respond to disasters. Generally, you're only going to need to make modest operational modifications. So again, you might have to do high-end personal protective equipment, or you may have to deal with an unusual infection like Ebola or whatever, but you're going to generally do what you normally do in all this. Again, you're going to have to sprint for critical issues that have a critical time element in them, but otherwise, you really want to focus on sustaining things. If it's not time critical, having people wait a little bit longer isn't going to change their outcome. Triage and rationing become important when you are way behind in your ability to meet the surge capacity. And in that case, you're going to have to make some decisions about who's going to likely benefit the most from the resources that are available. And this may need to be done at a facility level, or it may need to be done at a community level. So for example, a community might put some rules on blood utilization to protect a limited supply of blood that's available. Again, the issues are to try to find a scalable approach. So, for example, when we dealt with the tornadoes a few years ago, we ended up having to create 6 to 8 different trauma teams to be able to process simultaneously the number of major trauma victims that came out of this. Having a single trauma team would not have gotten the job done when it takes an hour to process one patient. The 8th patient would end up waiting 8 hours. So that's what we tried to do, and that's what I mean by being scalable here. One of the issues that we've recognized is that there's a significant learning curve of the authorities. And I think perhaps some of the infection issues over the last 15 or 20 years are an example of this. So for example, with the anthrax issues a while back, people recognized that you could catch anthrax from mailboxes, from people putting anthrax purposely in a mailbox. But the CDC and other people didn't recognize that until it happened 5 or 6 times. The same things happened with Ebola. They thought that we could just use universal precautions to deal with Ebola initially, and that didn't turn out to be the case. You really needed to go to a higher level of PPE than just standard precautions. So you need to be a little careful and circumspect when you're dealing with some of these things. I think perhaps another example of this is how we're dealing with flu recently. The CDC last year pointed out that people should urgently seek care whenever they first experience flu symptoms and seek out Tamiflu and so forth. Well, that ended up overwhelming our ER, and the odds of children having serious outcomes from flu is extremely small. So those are some examples where you need to be a little careful to make your own assessment of reality a little bit and be a little bit adaptable. This is another really important slide. One of the things that happens in disasters is we get tunnel vision and we focus on the disaster victims. And that's important but you need to understand that the patients that you see on a day-to-day basis are going to keep coming. And actually, they probably, in most cases, have more morbidity and mortality risk than the aggregate of all the disaster victims. So, for example, when we had the tornadoes, we had about 60 tornado victims that were significantly to seriously injured in the first 24 hours. But we also already had 30 patients in the ICU, and we saw 1,000 patients in the outpatient clinics the next day, and we saw 150 patients in the ED, and actually we had 3 patients that were not disaster victims that required immediate surgery, and we only had 2 disaster victims that required immediate surgery that day. So be very careful about that issue, because the day-to-day business you're going to have to keep doing, and there's a lot of morbidity and mortality lurking there. The other part is you need to have the resources to sustain your staff and those that are accompanying victims and patients as well. So particularly with weather issues, we had the snowmageddon in Birmingham past year. We had to have enough food and bedding and whatever to keep all the people that were visitors and whatever and staff in the hospital fed and watered and bedded for 3 or 4 days until enough of the ice melted that people could actually move again. People get frustrated with the inflow of patients sometimes. This is a frustration that you just need to get over. There's no way to control the inflow to patients, particularly to the hospital or the ED. In a practice, you may be able to control the spigot. But going on diversion or whatever else you're going to say or mass media announcements, it's not going to change. People are going to be scared. They want to come and get seen, or they actually have problems. So you're going to have to do it. So the best thing to do is don't focus a lot of effort on that. Focus on actually processing and dispositioning the patients instead. And when you're overwhelmed, you're going to have to look at augmentation issues, and we'll get into that in just a second. I think another thing that I've seen over the years is we get into this superhero mentality. And what happens is we end up having 100 patients, and we can take care of 75 well, and the other 25 we can't really take care of well, but we shoehorn them in and we hang on to them. And there's help that's reasonably accessible, and instead of sending 25 patients to where the help is or doing some other adaptation, we tend to just keep hanging on to them. And so, the inpatient attending, instead of having the usual 15 patients, now they got 35 patients and they can't keep on top of all of them. So be prepared that psychology happens. There's a few things, and I think these are all pretty tried and true, that you can do to make some resources available. You can reduce your elective and non-elective service, non-urgent services. You can use other venues besides the ER, for example, to provide low-level, low-acuity care. So making a satellite clinic into an extension of the ER or whatever. And you don't have to provide definitive care for everything right at the moment, so you can stabilize people and come back and deal with the definitive care a little bit later. Resource delivery is all about capability and capacity, and it's important to understand the roots of both of these so that you'll be more successful. Capability is the ability to do something. Capacity is the number of times you can perform that capability over a period of time. So you can have situations where you have sufficient, limited, or absent capability or capacity. And it's important to understand what you have, because the approach to fixing the problem is different. So typically you're going to have an inventory of items that you need to provide your services. If you have a bundle of resources that are needed to do a type of surgery, for example. You need the nurse, you need the doctor, you need the anesthetist, you need the drugs, you need the surgical supplies. Well, if you're missing any one of those required items, you don't have the capability to do it. So if you have a capability problem, you need to find how to produce the required resources for the bundle. That doesn't mean that you have to produce things that you would usually use, but you have to get down to the bare brass tacks and find what you need to make that capability available. If you have a rate limiting resource, then that determines your capacity. So if you only have one anesthesiologist, then you can only do 1 or 2 cases at a time. Whereas if you have 4 anesthesiologists, you can do 8 or 10 cases at a time. So the problem with a capacity problem is you need to figure out a way to scale it up so that you can meet your surge capacity needs. And usually shifting bottlenecks are very typical in these kind of things. And what I've personally found is a model where you have one group that focuses on just getting the clinical work done, and a second group that works on the administrative and thinking part of this, so that those people can make sure that the resources are being managed and figure out where to access them and how to apply them and so forth. So somebody's got to do thinking, and the other group has to do the doing. It's important to think in bundles, in my experience. So you need a bundle to do a celiotomy or a craniotomy. But if you think about it just in terms of scalpels and IV supplies and whatever, you make your problem a whole lot more difficult. So try to think in terms of bundles of capability rather than just widgets and adding a whole bunch of widgets up. You basically have 3 options as far as gaining resources. One, you have your current supply. There's reserves out there within your organization, and by heroic efforts, you can mobilize more people. And then augmentation, you can either bring resources in or you can ship the patients to where the resources are. And these are the things that you're going to have to work through with all of this. So for example, when we dealt with the tornadoes a few years ago, we were able to call in all the off-duty anesthesia people and all the off-duty surgeons, and we were able to get to the point where we could run 6 or 8 trauma codes at one time. We had a conversation with the hospital in Tuscaloosa, and they were sitting on 800 or 1,000 patients all at once at that point in time. And unfortunately, many of them were pediatric patients. And we had a conversation with them. Should we take some of our staff and take them down the road to Tuscaloosa and try to set up some kind of satellite function there? Or should we decline that option and instead focus on transporting the people to Children's Hospital where we could perhaps be more effective and efficient? And we decided on the latter one, and I actually think that was the appropriate decision in that context. And what happened was EMS did a super job. We had 25 critically ill patients, and this is chest tubes on a ventilator. They were all transported by standard EMS. And Alabama, a few years ago, made a decision to go to a statewide protocol-driven EMS system. So every protocol is a state-level protocol. And it was amazing that that worked extremely well. So I think that's something that perhaps people that are interested in the EMS side from other states may be interested in looking into a little bit further. But none of those children died. They all made it to our hospital. So that was pretty amazing. So we talked about augmentation. So the underlying issue there is that transport ends up being an issue there, and usually trying to bring them to the high-end pediatric resources is better than diluting your resources and going out to receive them. So generally, transport is preserved in a lot of these things. Communication is often preserved as well. If those two are out, or one of them is out, it becomes very difficult, and you'll have to adapt to that particular situation. The government particularly likes memoranda of understanding or contracts. We found that people did the right thing in the disasters we've dealt with over the last many years, so I'm not sure that memoranda of understanding at the clinical level are that important, but at the administrative and regulatory level, they continue to be pushed. And that seems to be a kind of a barrier, and people don't like to sign those kind of documents. Again, don't forget the people that are not disaster victims, and remember that you got to sustain your staff as well. So with that, let me remind you, this is what you do, and for many of us, every day is a mini disaster, and we execute that pretty well. So I think that hopefully this gives you a little bit of a background to go home and re-examine things. Let me talk about Katrina for just a minute, and I kind of call this the Everest-sized learning curve event, because that's exactly what it was. This was the first mega disaster that our country dealt with for a while, and we had made a lot of changes in how we respond to disasters, and we experienced a pretty big learning curve. So let me go through this just a little bit, and I think you'll see that some of the pediatric issues played out a little bit here. So one of the first issues was the situational awareness and protection or decontamination issues. When you deal with a disaster, you got to have security first. Nothing else will flow or happen until you get that. So when you decontaminate people, the first thing you need to decontaminate are their weapons, and then the next thing you need to decontaminate are the nuclear, biologic, and chemical issues. So we tried to send support to New Orleans to deal with the high-end pediatric needs down there. And what ended up happening was our helicopter and other people got shot at, and so we all had to come home, and we had no impact out of that deal. And as you all remember, once the military went in and reestablished law and order, the thing got unwound very quickly, but there were several days where it was just totally paralyzed because of that issue. I think most people are aware that you need to be able to use the incident command system to coordinate with external agencies in the government. That was kind of in its infancy during Katrina. I think we found that at the hospital level, internally, the ICS tends to be foreign, and so sticking with your usual internal organizational structure may not be a bad idea. But anytime you talk to emergency management external to the hospital, you're going to have to be prepared for the ICS issues. The other issue that came up is you need to be self-sufficient for at least a few days. The cavalry isn't going to come for at least 2 or 3 days in some of these examples, so you need to figure out what it takes to be self-sufficient for a little while. Let me talk briefly about some of the pediatric issues, and I'll try and save a few minutes for questions and all this. People were using shelters back during Katrina, and they were planned. The problem is that they didn't plan for children, and so they weren't prepared to support the activities of daily living, and they certainly weren't prepared to deal with the medical issues that children have in some cases. A particular pressure point was the special needs children, those that were on devices had to have some source of power, they had to have some source of supplies and support for things, and they lost access to their specialists, and there wasn't an easy way to get them in touch with specialists. Telemedicine wasn't really a big option back then. I think that may be solving some of these problems. But in Alabama, they've actually gone around and created designated shelters that have been hardened to be able to take care of children with special needs. And so those children need to know where their designated shelter is and be able to access it when the need happens. And family reunification was a huge issue with Katrina. It took several months for some of the families to get reunited. I know there was one anecdotal case where 4 or 5 families were claiming the child as theirs, and they ended up having to do genetic analysis to figure out who the child actually belonged to. The National Disaster Medical System, one of its roles is to provide mass evacuations in disasters, and this was the first time that this was actually exercised. This did not go well. There were major problems with identifying patients and tracking them. Basically, patients were just loaded onto C-130s and flown to wherever that C-130 was designated, and they picked cities with major medical centers and they accept them. There was no medical regulating, so people were not matched to a destination that could necessarily take care of their medical problem. So, for example, and this is hypothetical, a child that needed pediatric dialysis might have been flown to a city that doesn't have pediatric dialysis services. There was no triage process. There was no pediatric process. The government asked hospitals to send resources to the airport, and these resources stayed there for hours and sometimes even days on end waiting for whenever the flight was going to happen. And they couldn't tell you when the flight would arrive, but they insisted that medical resources be available at the airport so that when they got off the plane that they could immediately attend to anybody that got sick on the flight, because there was no medical resources on the planes. And as a result of this and a couple other issues, there was a national commission appointed, and this identified a bunch of pediatric issues. Unfortunately, we're still on our learning curve. Only about 25% of these issues have even begun to be addressed at this point. So this is another interesting document that if you're finding that this is relevant to you, you might want to look at it as well. I'll stop there, and I'll be glad to entertain any questions as time allows.
Wow, Steve, that's an incredible presentation. Makes you take kind of a deep breath, doesn't it? Thank you. How about some questions? I can't believe we won't have questions from this. Go ahead.
Dr. Kumar and I were liaison to the Medical Society in Pinellas County. The 3 states that have the most disasters are Florida, Texas, and California. And so we're fairly up and running as far as problems are concerned. Infectious disease, however, is a different sort of problem. And what we found was that the spouses of our care people did not want them to come to the emergency room where all the infectious disease was gathered. And in any crisis, 40% of the people that you think are going to show up don't show up. And it's for social reasons. It has nothing to do with not wanting to go there, but there's a little problem. We also found that if we had a way to have pets and families associated with hospitalized people, there was like a care place, that really went a long way into getting people to say, boy, I'll sure show up if my wife and my dog are going to be okay. The other thing we found was that, and Dr. Paul is on the transport information team, that the Pinellas County makes 450 runs a day. So it's staggering that we've got more hospitals in Pinellas County than South Carolina had. And the coordination is a centralized process. We learned pretty quickly that when Dr. Paul asked, well, what do you have on these wagons for kids? It didn't have anything. There was nothing. Nothing. So simply putting a pediatrician and an ER doc on that committee really, and then we had them trained to how do you intubate and do the things you got to do with kids. The other thing we ran into was that there's a company in San Antonio called Isolate, and one of our military guys told me about that. And you can get HEPA filters and UV lights put in your emergency room, and Bayfront had a big emergency room, and for $11,000, we got UV lights and ultra filters in all of our units. It cost $11,000. Hell, the doorknobs cost more than that. And so now you've got an environmentally safe area where the people who are providing the care can feel comfortable that they're not going to have a problem taking home to their kids.
So,
That especially happened with H1N1. So, and the other thing we found out from our transport teams, none of these masks or any temporary ventilating devices had filters on them. And so we went to all the wagons and said, put filters on these stupid devices, and that way the guys in the front line are going to stay in the front line. Little dumb things would make a difference, but I would always recommend that filters be put in any sort of ventilatory device, either in or out of the hospital, if cheap as can be. Number two is that the institute these UV lights and the HEPA filters, which will virtually eliminate the risk, and that will then bring the personnel more likely to come into the battleground where they're needed. But there's some amazing things that happen in disaster. And,
so Steve, let me he's talking about infectious disease disaster preparedness. What have y'all done at Children's about that?
Thanks for sharing your experiences. I think ours are fairly similar. And I guess at a 50,000-foot view, your approach seems to be one of the most effective ones, is to have a pediatric champion who works on that particular use case. And that seems to be effective at the hospital level and at other organizational levels as well. I think that you're also exactly right that you need to really think through how you're going to deal with it. Children are particularly problematic because they don't have cough etiquette and they don't clean their hands real well and so on and so forth. And you're right, if you end up spreading these germs all around and 15% of your staff ends up getting sick, that didn't help anybody very much in the deal. And I think EMS is particularly ripe in some respects for this. Most states have a EMSC program, and that's been the catalyst for a lot of the readiness on EMS side, but certainly having community participation by pediatric experts or wherever the other use cases are, I mean there's various ones here, is certainly going to be more effective than waiting for the EMSC program to permeate out to your particular community. I don't know if that quite answers your question.
We have another question.
Yes, Joy Kamar from Florida. Thank you very much for presenting this topic. It's very important, and there's a huge paucity of information related to this, specifically for pediatrics. I'm the team CMO for our NDMS DMAT team, and we work through a lot of these kind of things from an adult standpoint. Back in 2005, Journal of Chest actually put together a bunch of articles talking about critical care management and whatnot. And I'm kind of surprised till today, there still seems to be that positive information, especially from pediatrics and pediatric management. There seems to be this general belief that kids don't get involved in disasters, but they're the worst that are hurt next to, pregnant females. My question is, from your experience and from your connections, is there something that's happening at a national level to develop guidelines for mass critical care of infants, pediatrics, adolescents, whatever have you? Because we don't have any guidance. We're going by what the adult playbook says.
Sure.
And Steve, I'm going to add, if you'll throw in there, hardly a week goes by now that we don't see a school shooting.
Right.
And what do you do?
Sure.
I know Joint Commission just recently came out with something for hospitals for disaster management, but again, that's primarily adults. I know kids are little adults, but
Correct. I think that there's enough information out there to get you started, but you'll probably end up finding that you have to do some thinking of your own and work the issues yourself. So the references that I had in the slide there are probably a pretty good place to start, and that's based off of an EMSC spin-off. So that'll get you started. The National Commission report, and there have been probably half a dozen different IOM reports scattered over the last decade that have talked about one subsection of this or another. And so those are probably a pretty good place to start. Hopefully the after action report that I added to the website will stimulate your thoughts a little bit. I don't know that it'll provide exact answers to this. Clem is absolutely right. The school shootings are an issue. It's very interesting. These seem to be televised a lot more than they were in the past, but I'm not sure that the incidence actually has changed all that much. Typically in this country, when I looked a few years ago, it's between 100 and 150 school shootings or acts of violence a year in this country. So it's more common than you would think. I mean, I think if I hadn't told you the number, most of you probably would have picked a far lower number than that. But it's actually that high. The other part of this is when you televise these things, it begets more problems because people get trained to, how to do it. So, yeah, I think that's probably something that everybody probably needs to have on their list of the things that we're going to include in our disaster plan. And the problem with it is your options at your level are to learn how to hide and run and voice the alert so that everybody else can become aware of it. Few of us have police powers, so when there's a gun involved, the police powers with somebody with authority to have a gun to shoot back ends up coming into play. So that part of the solution you probably don't have. But I can tell you, any ER in this country deals with violence issues periodically. I mean, it's not profoundly common, but it's there. And the way things are going, probably one of you in this room that's not in a hospital setting has at least had some kind of threats or violence come up in your practice setting as well.
Yeah, I was just wondering if amongst all children's hospitals throughout this country, whether or not they have anything for critical care, because I know in the adult world we use self-escorts to, if we need to take people off of event, we could do that, but there is nothing like that that can help us for pediatrics. But thank you nonetheless.
Sure, yeah, I think there's things out there that you may be able to partially extrapolate from, but you're right, there's no codified reference for all that.
Thank you.
Sure, great questions.
We heard yesterday that perhaps there are not enough pediatric mental health professionals just to serve the everyday needs. In a case of a significantly widespread disaster, can adult mental health professionals just drop in and adequately serve the pediatric patients who aren't in access to the pediatric psychiatrists and social workers or whoever? Or is this something that ideally you would train those adult mental health professionals to have extra skills that they could provide in a disaster?
I think people are coming at this a few different ways. People are training non-mental health, non-traditional mental health people to pitch in, so I think that's showing some promise. So, nurses can do this, non-mental health physicians can do this, social workers can do this. It's not terribly complicated or doesn't require pharmacologic treatment in the acute stages of it usually. Absolutely, adult mental health providers can help. They have the core skills and abilities to deal with all of this as well. I think telepsychiatry makes it maybe a little easier. In the past, you kind of had to have people face-to-face to some degree to execute some of this. I'll tell you a quick anecdote here as well. Back in April, we had a interesting surge. We had 30 mental health patients being boarded in our ER. We only have 50 beds. And that lasted for about 2 weeks. And we were basically brought to our knees by this atypical disaster of having to board this many mental health patients. And we ended up dealing with it in a couple ways. Instead of waiting until the morning for the psychiatrist to finally get around to seeing them or whatever, we had 4 or 5 psychiatrists, and they came to the ER a couple times a day, and we were able to disposition many of them to non-inpatient settings. Otherwise, we would have had 45 being boarded there. And we had a few other things that we were able to throw at it. So that's an interesting experience. I haven't heard too many people have that kind of a mental health surge, but we had it, and it paralyzed the hospital.
I'll tell you what, let's do this. Steve, if you can hang around for a
Sure.
few minutes afterwards, I know there might be some other questions. It's time for lunch, and there's some box lunches. Mandy, you've got them outside the door over there?
Yes, and of course, feel free to bring them back in here for the social session.
Dr. Holt is up, and he'll be talking while you're eating. And so we'll be back in 15 minutes. And let's give Dr. Ball...